All right. And just a friendly reminder for those of you who are joining us for the first time, for those of you who haven't been here in a bit, we use first names to address one another to empower everybody to contribute, whether you're a clinician or a family partner. And we ask that any comments spoken aloud or put in the chat be respectful and non-judgmental, just to keep this as safe a space as possible. So we are going to have Christine and Kara present for the first 20-ish minutes of our time together. And then we're going to open it up so that you can ask questions, share your own units barriers. And at that time, I will stop the recording so that we can keep this kind of a protected space. Um, Without further ado, I'm going to introduce Christine and Kara and then pass it on to them. So, Christine is the manager of integrative care at Covenant Children's in Lubbock, Texas, and holds an academic appointment in psychiatry at Texas Tech University Health Sciences Center. With over 30 years of experience, she leads interdisciplinary family centered care initiatives that integrate child life, mental health, and expressive arts to support pediatric and neonatal patients and families. Kara is the lead mental health counselor at Covenant Children's Hospital. For 5 years, she has served the neonatal intensive care unit and associated women's units as a member of the care team. Her role is to address parents' mental and relational health concerns while developing the team's ability to provide trauma-informed and family-centered care. Thank you so much for being here, Christine and Kara. Go ahead and take it away.
Great. I'm going to get started and I'm going to transition over to Kara. I get to do more of the boring over high level overview and Kara will go really delve into more about the process. I want to thank you, Morgan and Malathi, for inviting us to be here and for adjusting the schedule so that we could both make it to be here today. I'm super excited to share what was successful in creating our program and I'm pretty sure, and I'm also really excited that Kara's here because she is the expert on this topic. So I'm going to give a little bit, you can go to the next slide. I'm going to do a little bit of just kind of a high level overview of our hospital because I do think it's really important to understand context because what works in our organization may not be the best process for other hospital systems. So to kind of give you an understanding and also of the families that we serve. So we are located out here in West Texas. You may be more familiar with Texas Tech University than Lubbock, Texas. People more hearing that. But we are out here very close to Eastern New Mexico. So Covenant Children's is a freestanding licensed children's hospital. It's one of eight in Texas, and there are not a lot in this area of the region. Because of our proximity to Eastern New Mexico, we serve a lot of families from Eastern New Mexico and the greater region. There's really 5 hours, whichever direction you go, is quite rural. Lubbock is about 300,000 people. So we are a level 4 NICU. Initially, when we started, our hospital has primarily been 43-bed NICU as a level 4, and this year we added a 9-bed small baby unit. So we have expanded, and interestingly, it's on a completely different floor of the hospital, so that kind of makes proximity a little bit different. We're part of a larger healthcare system. We're actually part of Providence Healthcare, which is, I think, like one of the largest Catholic healthcare systems in the country. So we're the Texas New Mexico region, but we're part of this much larger conglomerate as well. And a lot of that is in Western United States, California, Northwest. So we're the outliers out here in this part of the country for Providence Healthcare. We serve over 600 families a year. That was in 2025. We have about 600 families. So I anticipate this year it's going to be a bit more since we've expanded beds. And we were actually over capacity last year often and had to have babies in an overflow unit. So just a little bit of context about the department. So I came out here in 2014, initially to start an arts and medicine program. My clinical background, I'm a board certified music therapist and I'm a licensed professional counselor and had always worked as a music therapist in child life departments. And at Memorial Hermann, I actually spent 5 years and did work in the NICU, and that's kind of where I got really excited about working in NICU was there, and then came out here and was more in a program development leadership role. I love all these hearts popping up. Sorry, it's just really kind of so comforting. And so when I came out here, we had the department had two child life specialists and myself. And since that time, we have grown it to be this interdisciplinary. So we added music therapy, I think in 2015. So I was doing some music therapy, but I couldn't do a lot of clinical work as much as I wanted. So we hired a music therapist who actually did started doing some work in the NICU. And then I would say we have activities aides. We had some artists, and we in 2018. I'm going to go into a little bit of how mental health came here in a bit to kind of help you understand our process. It was not a typical way of getting care into the NICU. So I'll explain that. I'm very good at seeking opportunities when they arise and just taking them. So I think that's something I've tried to do. But so now we're this interdisciplinary team of about 14 staff. So we have about five different disciplines, including mental health, within this integrative care department. None of us are billable. We do not bill for services within our team. We are part of the care team. So that primary care model is kind of what we have right now. And so you can go to the next slide. I'll share just a little bit how Kara came to be part of our team. So in 2018, our foundation stated that somebody had a $100,000 private donor and they wanted to support pediatric, specifically mental health. There was no infrastructure at the time to house a mental health provider within our system. So, because of my mental health background, we put them within our department. I was like, sure, I would love to take this provider and put them on our team. So, at that time, we had an inpatient, he did inpatient work, ER, and some outpatient work for pediatric mental health. Then in 2021, in that summer, he left the position to take another job. And so at that time, our hospital had already started a partnership with Texas Tech Health Sciences Center, Department of Psychiatry, to create an inpatient and day treatment, an inpatient and a day treatment mental health program for kids. Because of that, and I didn't want to lose an FTE. Um, I thought, well, let's not lose this FTE. Let's not hire a pediatric person per se because they're going to build this whole unit and I may lose that position. And I will also add that in 2020, we hired a women's mental health position, outpatient person. So we had that already too before the NICU. And that was kind of through some serendipity of a behavioral health, adult behavioral health program closing, us allowing to take one FTE. We also had some state funding. So we created this outpatient women's mental health person that was doing a lot of like postpartum care, getting referrals from OBs. So at this time we had two mental health providers and one left. I have to really give a lot of credit to our leadership team at the time. I was simultaneously working on my PhD with a passion for NICU and was doing all of my dissertation work in the NICU and working directly with families, specifically on early relational development and family development specifically between mothers and their infants in this NICU context. So I got to know a lot of families during that time while I was working on my dissertation and really hearing a lot of their experiences of stress in the NICU. So I was really, and also I was delving into a lot of the research in that area as part of my own work. So I was really passionate about supporting families in the NICU and their mental health and well-being needs. So at that time, I was able to bring a proposal to our leadership team requesting that PD position, so I don't lose an FTE, because this was during budget time. I was like, I don't want to lose an FTE. So I proposed creating a full-time mental health provider primarily for our NICU. And the grace of all divine or all spiritual, it worked out. And they were like, yes, this sounds great. We had really supportive leaders at that time to say yes to something that was really new for us. What was really fantastic is that we hired Kara Pepper, who is, we could not have been more fortunate to hire a more competent and impressive person for this role. We did include our women's mental health provider at the time. The outpatient person was on the interview, as well as our NICU medical director. We interviewed several people, and Kara was the perfect fit. And here we are, almost 5 years later, and that's where we are today. So this is a budgeted position. It was not a philanthropy position. So it was fully part of our operating budget. It still is part of our operating budget. And as of this time, we do not bill for services. Care is part of the care team, just like our social workers. And so I think that's enough of me talking. So you can hear a little bit more now about the flow. And we did involve our PFAC members, but I'll let Kara kind of speak to that when she first started. So, Kara, share more about like your background, your workflow, and how it works and what we've learned.
Absolutely. So this has been a slow development over 5 years because we wanted our families to be the leaders in telling us what they needed. So when I first started this position, I was connected with multiple of our PFAC members who had had children in the NICU and conducted a survey with them, one-on-one interviews, and that is really the root of where we came up with what this position looks like. My training is as an LMFT. So I like to think of things systemically. I didn't want to ignore any family members. I wanted fathers, siblings, mothers, grandparents, everyone to be able to be supported. And I found that a lot of times in our NICUs, I feel like we are looking at, okay, is there a high Edinburgh score? And while that matters, that's not the only thing that tells how the family's functioning. And so we wanted to have a broader scope, which is part of why I'm so glad that we don't bill, because I'm able to slowly build relationships with families that would never seek mental health services, and I don't have to feel guilty about the financial aspect. Not that we ever need to feel guilty about the value of our services, but we work in a rural community with families that finances are part of the reasons that they accept or deny services. And so we're able to gain access to families and help them in that way. So one of the first things I did after I talked to the Family Advisory Council members was start trying to find who my advocates were within our NICU. I found that our medical director was very much on board with the work that we wanted to do. Our social worker was wanting extra support, and I found a few nurses that were very interested in learning more about what mental health in the NICU actually means. And so we started there. Started slowly meeting with families, introducing ideas of what perinatal mood disorders are like, why relationships are affected by high stress situations like the NICU, and slowly started gaining trust with our providers as I was working with those initial families. And so we played with a lot of different workflows. Typically, today, in the form that this has taken, I start with checking in with all of our nurses. I see who's on, I see what families are present in our unit, and I get a feel for what's the priority today. Do we have a crisis? Do we have a bereavement? If so, my presence and my focus is there. If I have the space, I start working on building those relationships with families. Psychoeducation is a huge piece of what I do because it empowers families in our region where there's not a lot of mental health education to have some knowledge and understanding about when they need to engage in help-seeking behaviors for themselves. Um, I do a lot of work trying to prepare families. Um, we slowly gained trust. Physicians brought me in on care conferences with families. So as we're talking about end of life decisions, chronic illnesses, those kinds of things, I get to be in the room and provide support for making sure that we're not traumatizing families in those conversations, that families aren't having trauma responses in those rooms, that they're actually able to hear what our physicians are saying and provide support in those ways. Similarly, with our even maternal fetal medicine providers, I get called in with our neonatologists in order to provide support for difficult conversations about genetic diagnoses, even in utero. So those are ways that I start building relationships with these families even before they actually hit our neonatal ICU. So that's part of why I coordinate so much with our women's units, even as a NICU primary provider, because we see that as we are preventing these things from being shocking, we are preventing trauma. And therefore, we're hopefully, and what we think is preventing perinatal mood and anxiety disorders, relationship disruptions, all of those types of things. Um, we operate based on the idea here that holistic care matters and that holistic care goes beyond the traditional look of psychotherapy services. So while I have some families that I may meet with once a week, every week for an hour, most of the times it's a 5 to 10 minute check-in with some psychoeducation and tool building. And then I connect them to traditional therapy following the NICU stay. Or perhaps if we're in a unique situation, I have spent up to 18 hours with a family in a day before, um, working in bereavement situations in unique cases. And so we really operate on the principle that our families deserve that care. But we also realize that diagnostics matter. And so we have collaborated with our social work department in order to make sure that we are actually assessing. Our social workers do a lot of our clinical assessment for us, particularly with the Edinburgh. And then on a consult basis, I address postpartum depression, high Edinburgh scores, trauma, those types of things. So that relationship and coordination has been key for making sure that this position is sustainable. Because we only have one therapist, we want to make sure that we're utilizing my time well. So things that can be parsed out to other disciplines, we do. We coordinate with chaplains a lot, social workers, and even our rehab team in identifying families that really need our support. Um, I think some other things we wanted to highlight is that we find that this is really ideal when it's collaborative with either a women's provider or with the NICU provider also working on the women's floors. And again, that's just based on our context. But we find that there is so much overlap between our women's populations, pre-existing relationship concerns, and our NICU that we have such a greater continuity of care when we're able to have the same provider following a family through their whole stay. And I will even take outpatients as well alongside our established outpatient provider just to make sure that these families are receiving the best continuity that we can. We have ethical boundaries, and yet everything we can do to flex within those to meet the family's needs, we will do. So I really have appreciated Christine and our medical staff and their buy-in on all these things. Um, we really believe that without the medical staff being trauma informed, this position simply can't do enough. So when I'm not on the floor with the patients, I'm spending time with staff, educating them on why families are reacting in certain ways, educating them on trauma responses, grief responses, so that they can properly identify patients for me to see, but also so that they can have empathetic interaction and trauma-informed interaction when I'm not able to be there facilitating those things. So that includes educational workshops that we do for our NICU. That includes attending staff meetings and presenting topics. And that includes being present for debriefs, helping even staff members access their own mental health care. So all of those things are included within the scope of my position. If we can go to the next slide. I'm going to throw it back to Christine to kind of just go through some basic tips here for what we're doing.
Sure. I think interdisciplinary integration is integral, for being redundant, to really the success of this program and really working together. We're a relatively small hospital compared to some other institutions. There are advantages to that. I think you really get to know people pretty well, and everything's in pretty close proximity to each other in terms of all our different disciplines. And I think, Kara has really developed a really good way of kind of triaging like different tiered relational mental health support. And I think that's critical because if you're going to have 600 families a year, she's not going to make every touch point to families. Some of them are short admissions and some you just may not be able to see, and some obviously may not need services or do not want services. And I think, Kara's been really great about having that universal visibility to families. We have it's called the NICU Nourishment Center. It is a beautiful space that we were able to have. I think we did it 2 or 3 years ago. It's basically a food pantry, 24-hour access for families, and like there's also like a community space as well. And we have a monitor in there that has kind of ongoing, it's kind of like a circular slideshow with information, but there's information about Kara, information for families to read while they're in there to kind of know that she's accessible. And, initially when Kara and I, we would talk about like, we talked about groups a lot. Like, how do you do group therapy? How can we do groups here? Groups are challenging in an inpatient setting. And so we trialed some different things and kind of discovered, I mean, how long have we been doing coffee time now, Kara? Like 3 years?
Almost 3 years. I had
Yeah.
two moms walk up to me and go, "We want to make friends." And I said, "Okay, tell me, please, how we can do this." And they said, "Well, that is a stupid question. Give us coffee. We are tired moms." And so we made the support group a coffee and pastries with crafts group that is very casual, but they get to come have supportive conversations with one another and have access to ask me questions at the same time. That's something that we've kind of done as an access point. And then, kind of continuing on from there, we have also developed an official informed consent process that covers all of our group things as well. We were operating under the general consent of the hospital, but we've decided that for mental health care, it is unique enough that we want families to truly have autonomy. And so we have them sign a separate consent for our mental health services. And that includes our therapy dog, myself, groups, all of those kind of things.
And that was relatively new earlier this year. It's something that we had started working on last year and, going through all the processes with legal review. And now it's part of the general, all the consent forms when they get admitted to the NICU. And I think the Edinburgh screening is also newer that we're screening NICU moms. What is the frequency, Kara?
So they are screened upon admission and then every 2 weeks following.
Okay. The other thing and I'll tell you, these are things we didn't anticipate. I'm not sure if in today's healthcare climate right now, we know there's a lot of financial challenges in healthcare, particularly nonprofit healthcare. I'm not sure if this position would have been easily as like, yeah, we're all in, as it maybe would have been 5 years ago. However, I think having 5 years, this embedded model would be extremely difficult now to remove because it's been such a big part of our NICU designation and the feedback we've received from NICU designation, as well as women's designation services for those levels, as well as meeting some of the criteria that the state of Texas has put out related to needs of, is it, remind me, Kara, it's the palliative care
Mhm.
and bereavement and loss.
Yeah, so the state now, and thank goodness we needed it, they now require palliative care services to be offered in certain situations, and that includes supportive care.
And of course, we started doing, a few years ago, being part of the, the NICU QAPI meetings as well as women's QAPI meetings, and whether it's track and trending data. I do think the data that Kara is tracking this year is really meaningful and important. So I'm just gonna let her highlight that, and then we'll go to the next slide, and then we'll go open it up, and it'll be really quick. The next one will be quick.
Yeah, so through an analysis of some data, we found that based on the average age of our population, in theory, about 35% of the women in particular that we are working with should have a significant mental health history. We have found that in our neonatal ICU, some months up to 60 to 65% have that significant history, which we know that a history of depression and anxiety makes a NICU stay more likely, but we were not expecting it to be double the average population. And so we're tracking and trending that this year to then decide next year what we need to do as an action point to make sure that these moms are getting initial support in the way that they need.
And the next slide is just some tips to just think about. We can leave this slide up as we go into discussion, but I think it's really important to kind of look at your context. What are your resources? What are your care gaps? Are there opportunities for any kind of grant or pilot funding and collecting that meaningful data to your organization? Length of stay is a biggie. It would be really interesting to see if it helps with length of stay. Really clearly defining that role and who that provider is. It may look different at other institutions. And LMFT was a perfect fit for our context and our culture. And, trying different pathways to know what's going to work best. Obviously, including your PFAC members and including the voices of families and hearing what their needs are, that can speak volumes also to your leadership. And then, like Kara mentioned, really building those care team relationships and finding early who your advocates are. And I think there would be an outcry from the staff if that position was ever even considered to be cut. I think it would not happen. There's other positions that they're freezing, but they will not. This is one that is it's really embedded now. I think it needs that time. I think if it was like 1 or 2 years, it makes it a little bit trickier, but 5 years, you are really part of that internal system and support for families. So I would love to hear what other organizations are doing, what other people are learning, what are some barriers people have on this. This is an important topic. So take it away, Morgan.
Thank you both so much. This was hugely helpful. We have a ton of questions in the chat. Um, First and foremost, I just want to say well done. And I think it's really cool that we have over 160 people joining us in the middle of the day to learn more about this topic. It's really heartwarming and it gives me a lot of hope for the future of mental health support in the NICU. I'm going to go ahead and stop recording.